Good morning, one and all. As a neonatologist, we are often called for attending deliveries and doing the resuscitation. Till now, we must have resuscitated thousands of neonates. But there is one neonate who is still lingering in our minds, and that is baby of S. It was a term delivery, born to a mother with uneventful antenatal course. All her scans were normal. So we were called for delivery, but the baby did not cry at birth. So we started with initial steps of resuscitation. We did face mask ventilation. We did not succeed. We tried to intubate, but we again failed. We tried using alternate methods like laryngeal mask airway, but again we could not oxygenate, we could not ventilate. So we had a difficult airway. And within 15 minutes of life, we lost this baby due to critical airway. The point to ponder here is, why did we fail? We failed because we were unprepared. We did not anticipate a difficult or a critical airway. We failed because we did not have right equipments at right time, at right place. We failed because we hardly train for such scenarios. We hardly have simulators which can train us on difficult and critical airway. On behalf of Department of Neonatology, I welcome you all to today's CGR. Esteemed faculty members, colleagues and dear friends, the topic for today's CGR is difficult airway neonates.
Thank you.
For next 20 to 30 minutes, we'll be covering this presentation under the following headings. What is a difficult airway? A difficult airway is any situation in which clinician experiences difficulty with face mask ventilation, laryngoscopy or intubation. It is important in difficult airway to determine the level of obstruction for optimal and intact survival of the neonate. There are various scorings to know the criticality of difficult airways, and most commonly used we have Cormack and Lance scaling. Why we have chosen this topic is because it's always challenging. It's a do or die situation. There are lack of appropriate equipment, expertise, and there are no neonatal guidelines for managing a neonate with difficult or critical airway. The incidence is very high. The incidence is 14 to 15% with a mortality rate of nearing 50%. And in one of the largest studies, it was shown that it is the human factors which contribute to the adverse outcomes in managing such babies. So all these are preventable. And the most common cause for adverse outcome was perseverance with the same ventilation technique. That is, we are doing the same thing repeatedly and expecting different results. Why this is happening is because we do not train our residents, we do not train ourselves for such situations. We recently did an online survey and we contacted about 15 centers, and out of these 11 centers did respond. And each of these centers had experienced at least one neonatal death in the past 2 years. But when we asked what was the action taken to prevent such future deaths, there was no response. Before moving further, it is important to know what is the difference between a difficult and a critical airway. A difficult airway is usually non-life threatening. The usual methods of ventilation fail, but we are able to oxygenate the baby with the help of alternate airways like laryngeal mask airway, and the common example being macroglossia. Whereas in critical airway, it is even impossible to ventilate these babies with alternative methods like laryngeal mask airway, and usually these babies require a multidisciplinary team approach and fiber optic bronchoscopy to manage such babies. The common causes in neonatology include subglottic stenosis and oropharyngeal masses. The important thing here to remember is always call for help, which we often forget. It is a teamwork, so whenever we are facing a difficult airway, you never know whether it is a critical or a difficult airway, so always call for help. Now, what makes a neonatal susceptible to difficult or a critical airway? There are certain anatomical and physiological peculiarities in a neonate which makes this population highly vulnerable. The neonates have a large head and short neck. The head size to body proportion is 19% compared to 9% in adults. As a result of which, whenever a baby is spine, the head tends to go in flexion, causing upper airway obstruction. We all know that neonates are nasal obligate breathers. Therefore, any nasal secretion, any nasal inflammation is poorly tolerated by neonates. The tongue is proportionally large compared to the oral cavity. Therefore, especially in babies who are sedated or in certain syndromes like Beckwith-Minden syndrome, it can be an important cause of upper airway obstruction. As we move further down, the epiglottis is relatively large, it's floppy, and it tends to cover the laryngeal inlet. The epiglottic fold, along with the aryepiglottic folds, which are short, they tend to collapse into the glottis, leading to severe respiratory distress and difficult airway, a condition which is called as laryngomalacia. The larynx in infants is placed at a higher level. It is more anterior and angulated, as a result of which the intubation is a difficult task even in a normal neonate. And the ET tube often gets dislodged because of this angulation into the anterior commissure. The larynx and the trachea of the neonates is funnel shaped compared to the cylindrical seen in the adults. This is because the narrowest portion in the airway of a neonate is the cricoid cartilage. So even if one is able to bypass the larynx, he may still face an obstruction. This is the result. That's why we use uncuffed ET tubes in this population, and even a minimal amount of edema can cause severe compromise in neonates. This can be seen in various causes, especially post-intubation. Apart from anatomical challenges, these babies, because of the rapid growth, they have high metabolic demands, which is almost twice as compared to the adult. The tidal volume is, however, relatively fixed. Therefore, for increasing their minute ventilation, they predominantly depend on respiratory rate. Because of the poorly developed musculature and the rib cage, the FRC is relatively low. The type 1 fibers, which are rich in mitochondria, are present in small quantities. Therefore, neonates are prone to easy fatigability. All these factors lead to rapid desaturation, and they tolerate even at 1 minute or 1 second of hypoxia very poorly. They desaturate precipitously when compared to children and adults. A small example is here we present that how a small change can have big impact on neonatal airway. Because of the small caliber of the airways, even a 1 mm increase in the diameter leads to decrease in the diameter by 50% and an exponential increase in the resistance. This is governed by the Poiseuille's equation, where R, resistance of the airflow, is inversely proportional to the 4th power of radius. This can be even higher when the flow is turbulent. Apart from these factors, the neonates have laryngeal hyperexcitability. Even a minimal amount of aspiration leads to laryngospasm and apnea. Besides these, the protective reflexes like cough, they are suboptimal or absent. We all know that hypoxia causes hyperstimulation, but in neonates it causes respiratory depression. These babies are often under the cover of drugs, especially sedatives and the drugs which cause respiratory depression. We also know that neonates are unable to maintain the body temperature, therefore they are prone to hypothermia. Hypothermia in itself is a respiratory depressant. All these factors make these patients vulnerable. Now it is important to anticipate. With the advancement in the antenatal diagnostic imaging, majority of these conditions are diagnosed antenatally. Antenatally, any history of polyhydramnios or hydrops should alert a clinician to a possible difficult or critical airway. This is because usually a neonate swallows the amniotic fluid, which causes lung distension and helps in lung growth. But if there is an airway obstruction, this fluid is not swallowed and it leads to polyhydramnios. Also, malformation anywhere can be associated with airway malformation. The most common malformation which is associated with airway malformation is cardiac malformations. Chromosomal disorders are known to be associated with difficult or critical airway, the common examples being Down syndrome. And always ask for history of neuromuscular disorder in mother or previous sibling. Postnatally, these babies present with stridor, suprasternal retractions. There is often a history of prolonged or repeated intubations, and always look for dysmorphism. The level of obstruction can be anywhere from nose to hypopharynx. The common causes in nasopharynx include conal stenosis, oropharynx, we can have cleft palate, macroglossia, and laryngomalacia and laryngeal cleft are the commonest causes in the hypopharynx. We will be presenting one cases representing each of these causes. A word about congenital high airway obstruction syndrome. This is an antenatal diagnosis and is because of near total or complete obstruction of the airway. Usually these babies present with features of high drops, distended echogenic lungs and flattened diaphragm. The most common cause being laryngeal atresia, and it is often unreported because they have a bad outcome. Majority of the fetuses, they die in utero. During routine intubation, our aim is to put a tube across larynx. And usually this is done by displacing the tongue to one side and pushing the tube inside. But however, because of the anatomical challenges which we discussed, all the axes, that is oral axis, pharyngeal axis and tracheal axis, they are angulated to each other. Therefore, to make an alignment, we usually place the neonate in a supine position and place a shoulder roll under the shoulders to make these axes align. And once we see the trachea, and we placed ET tube into the larynx. However, this is not always true. We may have a difficult airway or a critical airway, and this can be seen almost anywhere. For example, during the time of delivery or post-extubation, especially in VLBW babies or babies with prolonged intubation or repeated intubations, or during perioperative period. Now, what do we do then? Before telling you the answer, let us recapitulate the important key learnings from this part of presentation. First, to avoid trouble, one should always be prepared for the trouble. You should all have a definite plan A, but in case your plan A fails, you should always be ready with plan B or C. Failing to prepare is preparing to fail. And do what you master and master what you do. A difficult or a critical airway always creates a chaos, be it a seasoned clinician or a first year JR. So, how do we manage this chaos in our NICU? For that, I would like to call Dr. Akansha to present some of our own experiences.
Thank you, sir. We shall now begin with the case discussion. Now, this baby was brought to us who was born to a 30-year-old primigravida mother who was booked outside. Her antenatal scan at 36 weeks of gestation revealed a large neck mass in the fetus, for which she was referred to as SGPGI, anticipating a potential airway obstruction in the fetus. So after coming here, a repeat antenatal ultrasound and a fetal MRI was planned for the baby. MRI provides us with a more comprehensive global view. We can delineate the anatomy better, and we can have a look at the alignment of the mass with other vital structures of the head and neck, such as especially the airway. So herein we have a picture of the fetal MRI, wherein we can see that this is the fetus lying inside the mother's uterine cavity. We can identify various body parts of the fetus, such as the brain, the upper extremities, solid organs such as liver. Herein are the lungs of the baby, and leading to this we can visualize a trachea with some difficulty, and herein the anterior part of the neck lies a mass which is extending almost from the base of skull and coming up to the upper thorax, causing tracheal compression. So, we anticipated a life-threatening airway obstruction at the time of delivery of this fetus. So, what all can go wrong? It is difficult to ventilate this baby because we will not be able to position the baby well for providing face mask because of such a huge neck mass. This mass can cause difficulty in visualization of the larynx, and because of the tracheal compression, and such babies are also anticipated to have air leaks after resuscitation because of the pulmonary hypoplasia. And all of these can ultimately lead to a hypoxic brain injury if there is any delay in establishing airway for this fetus. Hence, To deliver this fetus, what should be the optimal delivery strategy? It should be done in an elective manner and under controlled conditions wherein we are prepared for with all the equipments that would be needed to manage a difficult airway and to prevent hypoxia while we are doing all the fetal airway intervention. The fetus has to be maintained on uteroplacental support so that while we take time to access the airway, the fetus keeps getting oxygenated and circulated on the uteroplacental circulation. And this procedure is what is known as exit or an ex utero but an intrapartum treatment. Although it is conceptually simple, but the success of such a procedure relies on a highly skilled multidisciplinary team and an extensive pre-operative planning. So a multidisciplinary team comprising of anesthesiologist, ENT specialist, radiologist, pediatric surgeons, maternal fetal medicine specialist and neonatologist was formed. And after the team was finalized, the parents were counseled regarding the need for the procedure, its outcome and what all could be the complications. The roles were assigned to all the members and were debriefed. The main neonatal issue was to secure a fetal airway and an algorithm was formed for the same. And since it was the first time this procedure was being done in SGPGI and it requires extensive meticulous planning, the procedure was rehearsed and reviewed multiple times step by step before the actual day. So in the operating room, a separate neonatal resuscitation trolley was prepared which consisted of all the equipments that could be needed for managing such a airway, including a straight video laryngoscope which was designed by our own anesthesia consultant Dr. Kanogia sir, straight laryngoscopic blades of number 1 and 2, rigid ventilating bronchoscopes in case direct laryngoscopy fails, and with cuffless endotracheal tubes of various sizes. We also kept endotracheal tube introducers or bougies handy for assisting the intubation. Apart in case the both of laryngoscopy and bronchoscopy fail, we were ready to manage the case with neonatal tracheostomy equipments and a laryngeal mask airway. So we'll discuss the fetal airway management part. Once the fetus was partially exteriorized, the upper part of the fetus, including the head, the upper neck and the torso, was delivered and the baby was positioned so that we can get an access to the airway. Endotracheal intubation was then attempted using a radiolaryngoscope assisted with a bougie, and after 2 failed intubation attempts, we could finally establish a definite airway and intubation was accomplished at 8 minutes. We would also like to share a video of the procedure so that wherein we can see the procedure and the picture that was displayed on the video laryngoscope. Erin, the fetus is being exteriorized. The upper part of the fetus is with the mess is delivered, and now we are attempting to visualize and secure the fetal airway using a video laryngoscope and endotracheal tube along with a bougie. Herein we are seeing that this is the epiglottis, and after clearing the secretions, we made an attempt to secure the airway, which was accomplished in 8 minutes. So after the airway was established, the baby was fully exteriorized, the cord was clamped and the fetal procedure of the exit ended there. The baby was then taken to neonatal warmer and was then shifted to NICU. On shifting to NICU, baby had some tachycardia with tachypnea. But on systemic examination, there was a grossly decreased air entry on left side. So we suspected pneumothorax. The transillumination test for the baby was positive and it was confirmed using an X-ray. And on local examination, it was a mass extending from mastoid process up till the upper thorax. So baby was started on mechanical ventilation. The pneumothorax was managed by putting a left-sided chest drain. And after the baby was hemodynamically stabilized, the tumor was resected at day 7 of life. This has been the entire course of the baby during stay with us. The neck mass was operated on day 7. Post-operatively, baby had wound dehiscence, which was managed with secondary resuturing. Baby was also noticed to have weakness of the left facial side. He suffered from left hypoglossal palsy, and there was persistent stridor, for which we did a direct laryngoscopy and diagnosed a unilateral left vocal cord palsy in this baby. The respiratory distress was managed by mechanical ventilation initially, and we could successfully wean off the baby to nasal CPAP by day 21, and then on heated humidified high flow nasal cannula. Presently, baby is on minimal oxygen. Initially received sepsis in the initial course, managed with TPN, and gradually shifted on express breast milk, which was given via orogastric feeds, but which baby continues to get because of severe GERD. So this is the present status of the baby. He is now 70 days old, on minimal oxygen with FiO2 of 25%, with multiple left-sided cranial nerve palsies, and in view of swallowing difficulties and severe GERD, he is on full orogastric feeds. Now, regarding the literature, there has been extensive literature which has been talked about this procedure abroad, but we could find only a few cases wherein this procedure has been conducted in some tertiary centers of India over the last 4 to 5 years only. So what we learn from this is that to manage a critical airway, a multidisciplinary team approach is required, and video laryngoscope is a valuable adjunct when we have to deal with such a airway, and team briefing and simulation is important before when we anticipate a critical airway. For further case discussions, I would like to invite Dr. Apurva.
Thank you, Dr. Akansha. I will be taking you to the next case where we had a challenging hypopharynx. This was a term 2.4 kg small for gestational age female with a significant history of polyhydramnios antenatally. The baby was born by an emergency LACS because of fetal distress. They had tried to put a orogastric tube in the baby, but they were unable to pass it, and hence the baby was referred to pediatric surgery SGPGI at 22 hours of life. At the time of presentation, baby had severe respiratory distress, for which the baby was transferred to neonatal NICU. At the time of presentation, baby had tachycardia, tachypnea, signs suggestive of shock. He had retractions, crepitation, suggestive of pneumonia, and he also had excessive frothing from the mouth. When we tried to pass an orogastric tube, we were not able to negotiate it beyond 6 centimeters. There were no other significant dysmorphisms or malformations noted in the baby. So as an emergency management, we first took care of the respiratory distress. At the time of presentation, baby had a saturation of 80% on 100% oxygen. He had mixed acidosis with both high PCO2 of 80 and a bicarb of 16. So we initially started with face mask ventilation, with which we could raise the saturation to 85%. And for a definitive airway, we first tried the direct laryngoscopy, in which we failed to intubate the baby. It was followed by a video laryngoscopy, but again there was an intubation failure. So we decided to use an alternative airway. We used a laryngeal mask airway of size 1. This was the baby, and we were able to ventilate the baby on conventional ventilation using a laryngeal mask airway. At 2 hours when we carried out the blood gas, the pH had improved slightly to 7.1. However, the PCO2 was still high. So we decided to shift the baby on high frequency oscillatory ventilation. On that, we were able to ventilate the baby. We were able to oxygenate as well as ventilate the baby. And there was an improvement in the PCO2 to 50. We suspected a subglottic stenosis or a tracheal stenosis, since we were not able to negotiate the ET beyond the vocal cords. For the definitive diagnosis, we planned to do a CT scan and bronchoscopy. We took an ENT consultation to establish a definitive airway, and a tracheostomy was planned. But since the baby had very low general condition, they had planned an on-table tracheostomy with a high-risk consent. However, the baby had been having refractory shock. We tried to resuscitate him with fluids, inotropes. Baby also had sepsis with disseminated intravascular coagulopathy, for which we had transfused the baby with PRBCs, FFP and platelets till the baby had pulmonary hemorrhage and eventually had cardiac arrest. So unfortunately, before we could establish a definitive airway or even diagnose the baby properly, we lost the baby at 50 hours of life. A word about a laryngeal mask airway, or a broader term would be a supraglottic assist devices. They were invented by Dr. Archie Brain in the year 1981 and got an FDA approval in the year 1990. They provide a better seal between the face mask and is less invasive than an endotracheal tube. They form a low pressure airtight seal against the glottis. They have been used in neonates. Apart from the difficult airway, they are very commonly used in providing short-term anesthesias because of their less invasive nature. And they've been used in neonatal resuscitation also and have been found useful. And in some cases, they've even been used to administer surfactant in preterm babies for respiratory distress syndrome. When we reviewed the literature regarding the use of LMA in neonatal ventilation, we found, despite extensive research, that there were only few case reports from all over the world. In one of the cases, they had used it in a neonate who was 10-day-old and had a tracheocolon syndrome with upper airway obstruction, and they were able to ventilate the baby for 4 days. In another case, they had used it in a preterm baby and were able to use it for a maximum of 44 hours. And another, they had used it in an emergency case in a helicopter transport. And in none of the cases has anybody used it for high frequency oscillation. So the key points that we learned from this case were that we should timely introduce an alternative airway if we are not able to intubate. And LMA can be used effectively in acute settings till we establish a definite airway. And LMA was able to deliver even high frequency oscillation very effectively in our case. Another case where we had a challenging nasopharynx and oropharynx. This was a term baby who was 2.5 kgs male, was born outside. The pregnancy was unbooked with no antenatal ultrasounds and the baby was delivered at home. He had presented with a large mass in the oral cavity on day 4 of life. On examination, he had tachypnea, tachycardia and signs of mild respiratory distress. This was the baby, and we could see that a large mass was protruding from the oral cavity. It was midline, it had hair over it and it had variable consistency. On lifting the mass, we realized that it was arising from the hard palate and it was difficult. We anticipated a difficulty in visualizing the larynx, and if we had to intubate the baby, this mass could have compressed the endotracheal tube. We did a CT scan in which we saw the extent of the tumor. It was even encroaching upon the nasopharynx, the oropharynx, and coming out of it. It was composed of bone, fat and soft tissue. So initially for the airway management, we did positioning, we used nasal prompts, but the respiratory distress of the baby was worsening. So we planned to intubate the baby. We anticipated a difficult face mask ventilation because of the large mass on the way. We anticipated that we may not be able to visualize the larynx very well and negotiate an ET as easily as we usually do. And there was a likely compression of the endotracheal tube also from the mass. So we decided to use a flexometallic tube. It is a tube which has a metal coil running all around it. So it is more flexible and the lumen is maintained even after a mass over it. I mean, it is very difficult to compress the ET. If we compare it with a regular ET, it is relatively flexible and hence difficult to intubate. So we usually use a stylet with it. It has a metal coil all around it and hence it can be easily seen on an X-ray. The minus side of this ET is that the connector is fixed, so we cannot alter the length of the ET, which we usually do in case of a neonate. So for this baby, the nasopharyngeal mass was excised on day 14 of admission, and the histopathology was suggestive of a teratoma. We had managed the respiratory distress by ventilation, and we were able to extubate the baby 2 days after the surgery. Baby also had pneumonia and meningitis, for which we had covered the baby with antibiotics. Initially, we had started the baby on orogastric tube feedings, and later on, Since there was a cleft palate post the repair, we had to put the baby on long nipple bottles specially meant for cleft palate babies. So this was the baby in the follow-up. When we did a literature review over the use of flexometallic tube, we found a positive literature. We found an Indian experience from the AFMC Pune where they had used in the Department of Anesthesiology in over 300 patients for nasal intubation and various oral surgeries, and they found that they were able to negotiate the flexometallic tube easily without causing any nasal trauma. Even we have published this case in BMG case reports. So the key learnings we got from this case was that face mask ventilation may not always be successful, and flexometallic tube is a very useful adjunct in cases where we deal with an oral mass, that too so large as we had it in this case. Next, I would like to invite Dr. Vasantan to continue the presentation.
Thank you, Dr. Apurva. Now I will be discussing a general approach how to relieve the obstruction in cases of difficult airways. It includes essentially 5 steps. Step 1 is formulating a team. The team should be multidisciplinary, including all consultants dealing with difficult airways. They should identify a senior leader who can manage the scenario and has got expertise, and the roles and responsibilities should be well defined. And case details should be discussed among all the team members. One should be very clear whether it is primarily an anatomical problem which causes a difficulty, or it is because of an extrinsic compression such as a mass or vascularity. This is followed by, we should form a checklist of difficult airway equipments. Apart from normal neonatal resuscitation, one should also include video laryngoscopies, boogies, flexible bronchoscopies, endotracheal tubes of different sizes, and tracheostomy tubes. Step 4 is a difficult airway algorithm. There is no definite algorithm for newborns for difficult airways. The general principle is to move from less invasive procedure to more invasive procedure, and to start with more confident procedures to go ahead with less confident procedures. Followed by, we should practice on simulation and debriefing. I would want to explain the step 4 of formulating a difficult airway algorithm. The first important step is positioning the baby. The baby should be positioned in such a way that jaw thrust should be applied and it should be in sniffing position so that airway is well open. In babies with difficult airways, particularly with craniofacial anomalies, one may have to use adjuncts such as nasopharyngeal or oropharyngeal airways. There are scenarios where, in spite of this, baby can go into respiratory failure. So there will be a need for intubation. In babies with difficulty intubation, one can better visualize the larynx by applying cricoid pressure. But even applying cricoid pressure, if you are able to see the larynx very narrow opening, then you can insert the ET tube assisted by boogie, or you can use a smaller ET tubes. The procedure of intubation can be made more successful by using a video laryngoscopy. In case if the intubation is still failure, then we should use a temporizing measure, which is laryngeal mask airway. As we use laryngeal mask airway, one should always call for a senior person to help. In resource limited setting, one can try further intubation attempts. But in cases of multidisciplinary backup is there, then one can try flexible bronchoscopy, which can be inserted through the laryngoscopy with railroading of a ET tube. This is called as fiber optic intubation. In scenarios where there is no access is still possible, then the only option left is anterior neck dissection procedures such as cricothyroidotomy or a tracheostomy. The most important step is the step 4 and step 5, where we are less confident because of less exposure. There should be more stimulation training in those scenarios. So all team members should undergo stimulation training with the help of neonatal aid, and also there should be a team mock drill to check the better coordination and time management before dealing with the case. After these steps, there should be a debriefing. It helps to identify the potential areas where the problem lies, and we can do a self-assessment of simulation practice either by using targeted checklists or by using a video recording procedures. Now I would like to share our experience in the past 5 years. We have encountered around 2,167 admissions, out of which around 30% of babies were admitted in NICU because of respiratory distress. Around 4% of the babies had a difficult or a critical airways. These are the general cases, the most common being post-extubation airway edema, where we have managed the baby by gentle positioning or using a smaller ureter tubes. The second scenario is being a post-tracheoesophageal repair, where we have encountered a difficult airway and managed with positioning and smaller ureter tubes. We also come across some of the rarer syndromes such as charge, Warfarin syndrome, where we are able to manage with urgent airways and also gone up to the extent of tracheostomy. 2 mass lesions have been discussed previously, and we have come across 2 cases of aberrant right circulation artery causing compression, which were managed by smaller ET tube intubation followed by surgery. But there are 2 cases of critical airways which we have missed mainly because of the one case because of the sepsis and other cases because of failure of resuscitation, even though we attempted cricothyroidotomy in that case. So as you know, now the training is the core important step. We routinely train all our residents, PDCC, DM residents and staff nurses in difficult airway training. So every 6 monthly they will be trained about intubation and also laryngeal mask airway. And because of the importance of critical airway, we have developed our own impactful, innovative simulator, which is called as Dirac cricothyroidotomy trainer. For the general audience, what is a cricothyroidotomy? Cricothyroid membrane is a membrane between the thyroid cartilage and the cricoid cartilage. In adults, during an emergency situation such as cannot intubate, cannot ventilate situation, as an end result, this membrane is punctured using an angiocath to facilitate oxygenation. But in newborns and pediatric age group, it is associated with a high failure rate. So keeping this in mind, we developed our own innovative simulator where we used a corrugated ventilator tube representing the airways and these balloons representing the lungs. We used a 24 gauge needle for piercing the cricothyroid membrane, and with the help of this we are able to achieve good lung expansion. Advantage of using our own trainer is it is an indigenous, reusable, reproducible, and we are able to produce it with a low cost. It is developed by one of our PDCC resident, Dr. Asta, under our guidance of our HOD sir. Apart from this, we trained this trainer as a part of workshop around 30 participants all around the Lucknow from various medical colleges. During the training, we used our own questionnaire, around 15 questions with multiple options, and we tested the knowledge and skill, experience and confidence about using a cricothyroidotomy procedure, and we are able to appreciate that their experience and clinical skill and knowledge improved significantly after using a simulation. Apart from this, we also use the simulator as a part of national training workshop in Bangalore, where we trained around 25 participants. As a way forward, we are in the process in the final step of building our own simulation center, which is called as Neonatal Advanced Simulation Training and Research Center, called as NASTAR. It is under the guidance of WHO and Canada, where we intend to do advanced simulation training, neonatal resuscitation, LMS, difficult venous access, and echo and ultrasound training. Conclusion: anticipation and planning is needed. Multidisciplinary teamwork is needed for success. Simulation training is need of the hour, and indigenous innovations are very much possible. I would like to. This achievement is not possible without any teamwork. So I would like to acknowledge all our team members, including our residents, MRH team, pediatric surgeons, anesthesiology, ENT and radiologists. Thank you.